it's quite a confused area because there are so many different agents and there are so many different targets that are being developed. And as we've got increasingly knowledgeable about all the different subgroups of AML patients and all the different disease genotypes, it's become increasingly complex which targeted agent to use in which particular areas. So certainly the menin inhibitors are currently at fairly advanced stages of development, and they seem to have their main activity in patients with NPM1 mutated and KMT2A rearranged disease. So it's going to be very interesting to see how they're best deployed, and there will be studies of them in combination with more conventional backbones like azacitidine, venetoclax, and potentially intensive chemotherapy in those subgroups going forward. It will be interesting to see in the intensive treatment space how venetoclax combines with intensive chemotherapy backbones and how that pans out in prospective trials going forward. And then there are many, many other agents, and there are some quite exciting immunotherapeutic approaches that are in relatively early stages of clinical trials now, which I probably can't list in the context of this answer, but it's going to be fascinating to see how we best incorporate them and how the treatment landscape evolves over the next few years. In particular, how some of these so-called non-intensive options begin to sort of move into the intensive therapy space.